Hello, I'm Dr. Jim Epstein, and this is Best of the Day from the 2013 meeting, the American Society of Hematology. It's Tuesday morning. The meeting is pretty much ending up. It's been an amazing meeting, especially for multiple myeloma docs and CLL docs. And we're joined this afternoon by Dr. Jennifer Brown from the Dana-Farber Cancer Institute to talk about some of the amazing data this year presented in chronic lymphocytic leukemia. Jennifer, thanks so much for being with us.
It's a pleasure.
Well, we were talking off camera before about how CLL has evolved tremendously in the last few years, remembering that when I was initially in training, we had chlorambucil, prednisone, cyclophosphamide, and that was about it. And then Michael Keating brought rituximab and the FCR regimen along in the last 10 years or so, but there has been a tremendous and very exciting evolution and really paradigm changing advances in chronic lymphocytic leukemia.
Yes, both the addition of chemoimmunotherapy with the expansion from fludarabine to fludarabine rituximab to fludarabine cyclophosphamide rituximab, then bendamustine rituximab, and now in the last few years we're having that paradigm now shift to the novel targeted agents, which are looking so promising, and we heard quite a lot about at this meeting.
Right, the BCR signaling pathway inhibitors. That's great. Well, let's start off. We'll try to divide this into segments so that people don't get too fatigued listening to us go on and on forever. So let's talk about frontline treatment. One of the trials that we've been waiting for years is the German CLL study group, CLL-10. Every year I would ask, is CLL-10 going to be presented this year? No, it finally made it. And this was the frontline FCR versus bendamustine rituximab. And when the data came out, I thought, well, you know, that's nice. It's not terribly surprising. But in view of all the new agents, I wonder how significant that data is. So tell us about the trial and the results and what you think we can take home from this presentation.
Right. So this study was the follow-on study for the German CLL study group in their young fit population, where they had previously done CLL-8, adding rituximab to fludarabine and cyclophosphamide, and finding actually an overall survival benefit, the first early overall survival benefit that we had seen in any CLL trial at that point. And then with the advent of bendamustine rituximab, which is such a well-tolerated regimen, the Germans sought to compare that BR regimen to the FCR regimen, again, in the young, fit CLL population without major comorbidities.
Similar to what they'd done in follicular lymphoma with R-CHOP and BR.
Yes, exactly. And I think the trial came out more or less how many of us might have predicted. It did show an advantage for FCR in terms of complete remission and progression-free survival, but that was at the cost of somewhat greater toxicity, albeit in the setting of the fact that the Germans have never mandated the use of growth factors or antibiotic prophylaxis during their studies. And I do think that the addition of growth factor prophylaxis or antibiotics would mitigate that toxicity. So on some level, the upshot is that in the younger patient population, and they did do a subset analysis based on age, under 65 versus over 65, the benefit of FCR was particularly greater in the under 65 population, whereas it was a little less clear in the population over 65, which was probably more susceptible to some of the toxicity.
And there may have been more dose reductions and delays in that population.
Right, and this is more or less what I think most of us have seen in clinical practice. But FCR did win, but not resoundingly. And so for the Germans, for their studies going forward, the standard chemoimmunotherapy for young fit patients is FCR, which I agree with. But there's probably an intermediate population based on age and moderate comorbidities where BR would still be a reasonable upfront chemoimmunotherapy.
Very good. Well, then the plenary session presentation that was really exciting was the obinutuzumab chlorambucil presentation. And chlorambucil is not used that much anymore in this country, but it's still used quite a bit in Europe, especially in patients who are older and have comorbidities. So this was actually a 3-arm trial. So tell us about the trial and what they reported in the first stage of the trial, and then what was reported during the plenary session here.
Right, so this was the CLL 11 trial, which is more or less complementary to the CLL 10 we were just speaking about, except in this one is for the older or comorbid patients. And the 3 arms included a chlorambucil arm, a rituximab chlorambucil arm, and an obinutuzumab, formerly known as GA101 chlorambucil arm. And GA101 is a novel type 2 CD20 antibody, which has better direct cell killing and enhanced ADCC compared to rituximab.
Right.
And in the initial stage 1 analysis, they'd actually first presented that at ASCO. Advantage was seen for GA101 chlorambucil compared to chlorambucil alone in response, complete response, progression-free survival, and also MRD negativity. And that served as the basis for the recent approval of obinutuzumab with chlorambucil for upfront therapy in the United States. Now, they updated that stage 1 analysis in the plenary session because there's now an overall survival benefit for the obinutuzumab chlorambucil arm compared to chlorambucil. And that's the first overall survival benefit that's ever been shown in this older patient population in CLL. Right. So again, fairly remarkable. And the stage 2 analysis was a direct comparison of the rituximab chlorambucil to the obinutuzumab chlorambucil arm. And I think that's what most of us were really waiting for because we haven't had many head-to-head comparisons of anti-CD20 antibodies.
In rituximab, chlorambucil looked better than single-agent chlorambucil also.
Yes, that's true. And there was no direct comparison, but the median progression-free survival for the rituximab chlorambucil arm was about 15 to 16 months versus about 23 months for the GA101 chlorambucil in the initial stage 1.
Very good.
No overall survival benefit for the rituximab chlorambucil, though.
So obviously, obinutuzumab is going to be combined not only with chlorambucil, a drug that's not used that much in this country, but people are going to want to use it as a replacement for rituximab in other regimens, in the FCR regimen or the BR regimen. And you presented some data combining obinutuzumab with bendamustine and just bendamustine alone. In fact, it was sort of a parallel comparison of obinutuzumab FC versus obinutuzumab bendamustine. So tell us about that, how big this trial was, and I know it's probably not fair to compare the 2 arms because the numbers weren't that big, but what was your experience with the trial, and what kind of impressions did you get?
Mm-hmm. So this was a small phase 1b trial. The goal was really to establish the safety of combining obinutuzumab with bendamustine or with FC. And there were 2 parallel cohorts. Different centers chose a cohort. So our site participated in the obinutuzumab FC arm, as it turns out. The data showed that the safety profile was really pretty similar to what we would expect for obinutuzumab in other contexts. Namely, there are infusion-related reactions which are significant and more than rituximab, so need to be managed very carefully, but are manageable. Neutropenia did not appear to be worse in the combinations with obinutuzumab, based, again, historically on what we would expect with rituximab. The response rate and tolerability in the bendamustine obinutuzumab arm was excellent, with a 90% response rate and most patients finishing therapy. There were 2 who stopped slightly early for neutropenia. The obinutuzumab FC arm, the one that we participated in, was an extremely potent regimen, and the patients that we treated did extremely well. There were, however, in this multi-center study, a number of patients who dropped off that arm for various reasons and were not fully evaluable. The arm was small, so it's difficult to know if this was just a patient selection problem, essentially a random phenomenon, or if maybe there was a little bit greater toxicity than one would see with FCR. So I think a larger study would probably be required to elucidate that for the FC obinutuzumab.
So I know the way obinutuzumab is given, it's initial 100 milligrams and 900 and then eventually 1,000. Sort of similar to the way ofatumumab is advanced. With it being a humanized monoclonal antibody, I'm surprised that the infusion reactions are greater than with rituximab, but I understand most of the reactions are just with the first cycle, and after that, they're not as much of a problem.
That's correct. The great majority of infusion reactions are actually the first day, the 100 milligram dose, and they are ameliorated by using highly potent corticosteroids, methylprednisolone or dexamethasone, rather than hydrocortisone, as well as using the low dose. I think it's really because the antibody induces such potent immediate killing of the CLL cells that we see the infusion reactions.
Right. Has tumor lysis syndrome been a problem?
No, tumor lysis syndrome hasn't been a problem.
Oh, that's interesting. Okay, great. Well, let's move on. Michael Halleck presented the data of the German CLL study group CLL7. And this was another FCR regimen, and they took a look at early stage CLL. And a lot of times they say, well, you shouldn't treat CLL until patients really have symptomatic disease, or they've got cytopenias, or they've got significant adenopathy. But they looked at Benet stage A and defined some of them as being high risk, and then randomized them between continued watch and wait versus early intervention with FCR. So tell us about that. How did they define high risk? And what did they find in the group that they treated with FCR, as opposed to the group where they waited until there was definite progression?
Mm-hmm. So the definition of high risk, I would say, is relatively well established in terms of those factors that lead to a shorter time to treatment, even in early stage patients. And they required that patients have at least 2 among a list of risk factors that include the higher risk cytogenetic abnormalities like 11q and trisomy 12, that include elevated thymidine kinase, which they use frequently in their trials but is not so widely used in the United States, elevated beta-2 microglobulin, unmutated IGVH, ZAP70.
Right.
And that identified about 25% of the patients as being higher risk, despite their very early stage disease. That subgroup was then randomized to either receive FCR immediately or to wait and follow usual standard of care, proceeding to treatment when the disease progressed. So they found that, as one might expect, the group that received FCR early did not have further therapy as often during the study as the group that didn't receive FCR, which did proceed to therapy sooner. Now, that's probably not the best endpoint for studies such as this, because obviously the group that gets FCR early is getting treatment. So many of us would focus more on time to second treatment in both groups, which they don't have that data yet because the follow-up is relatively early. Or actually, ultimately, the question is really overall survival. And they did address that question. The deaths, there were 10 deaths on each arm, and those were matched. And I did note that there were 3 possibly treatment-related deaths on the arm that got early FCR, but on the arm that didn't get FCR, there were several CLL-related deaths, which were not seen on the FCR arm. So that was fairly balanced at this point in time, no difference between the arms. And really we'll need further follow-up to see how that plays out over time.
How did the progression-free survival for those patients who did get early intervention compare with what they would have thought was their low-risk Benet stage A patients?
Right. So the low-risk patients did better than either of the higher-risk patients. So their model for defining risk was validated in that sense.
Very good. So looking at these upfront trials, especially the CLL10 and the CLL11 trial, how great do you think the paradigm shift is with this? Is this going to present a new standard for frontline therapy with obinutuzumab along with chlorambucil? Do you think this is going to get adopted in the U.S., or do you think people are going to just continue to use FCR and BR until there's additional data with similar to the regimens that you participated in, substituting rituximab with obinutuzumab?
Right. So for the younger patients, I think that people should continue to use FCR, and then that may veer into BR for somewhat older patients. It's not clear that CLL10 will have a major impact on that. For CLL11, it's a little bit more complicated. The data with obinutuzumab and chlorambucil look quite good. I personally will use this regimen in that patient population. Ideally, from a United States perspective, we might be interested in how obinutuzumab chlorambucil compares to bendamustine rituximab in some of those patients, because many of those patients on that study were not extremely high risk. I think they are patients that many of us would have considered could have gotten bendamustine rituximab. And so it's a little bit hard to know how that compares, but I would say that the progression-free survival is in the same ballpark as of the current study follow-up, and tolerability may be better with the obinutuzumab chlorambucil.
So are there plans to do obinutuzumab bendamustine versus BR trial?
Not that I'm aware of.
Would be an interesting program.
Yes.
All right, very good. Well, we'll stop here, take a break, and then we'll come back and talk about some of the amazing novel agents, and many of which you've been involved in the trial. So thanks for watching this segment on Upfront Therapy for CLL. We'll be back in a minute and talk about some additional data from this year's ASH meeting.